Welcome back to part 2 of my update on dizziness in long COVID. I'm Dr. Tim Robinson, formerly a family doctor GP for 30 years, now working in Long Covid Services for 5 years. I post on all the usual podcast channels and also on YouTube. I hope you find them helpful. Obviously, if you do, please click subscribe, share with others. I want to get this out there to as many of you who have long COVID as possible, especially now, certainly here in the UK. A lot of the long COVID services are being withdrawn and, you're being left high and dry. And, I want to support you and give you trusted advice and guidance. So, my usual disclaimer, of course, any advice or treatment that I give in these podcasts and YouTube videos, please do not consider until you have talked to your own doctor. So there we are. So part 1, basically, I talked about dizziness, this wide term that means so many things to so many different people. I talked about the symptoms and the different presentation and the diagnoses, and then, touched on the causes. Okay. In part 2, it is basically how we're going to treat it. Well, before I get into it, let's just sort of do a quick resume, a quick recap. Basically, when I sort of started out in part 1, I talked about the 3 groups of symptoms and hence 3 diagnoses. And the 3 groups of symptoms, all under the umbrella term of dizziness, are as follows. Remember, first of all, there's the group. Patients tell us, I feel dizzy, I've got giddiness, I feel vertigo, it's like the room is spinning. And that's caused by viral vestibulitis, labyrinthitis, or BPPV, or Meniere's disease, or vestibular migraine. So that's the first group. Second group was patients saying, I feel wobbly, unsteady, like being on a boat, like being on a pontoon, like being drunk. And the commonest cause for that is cervical spondylosis, osteoarthritis, arthritis of the neck vertebrae. And then the third group of symptoms, patients say, I feel lightheaded, I feel faint, it feels like I'm just about to black out. And that's due to dysautonomia, dysfunction of the autonomic nervous system. So, what are we going to do about it? Well, first of all, like I said, new symptom, off to the doctor, let's get a diagnosis, all right? And the doctor will be able to treat accordingly. So, let's think about the treatments. So, first of all, this is group 1. The group 1, the dizzy, giddy, vertigo group. Yeah, room is spinning, that group. So for vestibular labyrinthitis, this vertigo, there is an excellent drug, which we've been using for donkey's years, prochlorperazine stematil. 5 milligrams 3 times a day. It's very good at dampening down those symptoms of the vertigo, the room spinning, the giddiness. Often with those symptoms, you have nausea. Well, what are we going to do with that? And just as a quick aside, the reason for that is that the balance center is right next door to what's known as the chemoreceptive trigger zone, with the nausea, the sickness center in the brainstem. So if the balance center has been affected, then next door to it is the nausea center. So often they go hand in hand. Okay. So nausea. If you feel sick, you might be sick. So actually prochlorperazine is very good for not only that vertigo, but it's also a very good anti-emetic, anti-nausea, anti-sickness tablet. You can have it in a dissolvable form, a buccal form, they call it. So buccal stem, 3 milligrams 3 times a day, which it dissolves under the upper lip or lower lip. Take your choice, take your pick. And that is very good at dampening down nausea as well as the vertigo. Other drugs that we use for nausea, cyclizine, ondansetron, again, these are sort of commonly used anti-nausea sickness drugs in general practice. Your GP will be very familiar with both of those drugs. They've been around a long time. They're very safe. So that's vestibulitis labyrinthitis. What about vestibular migraine? Well, no surprises, okay, that actually the treatments are going to be the same as migraine treatment, common or classic migraine treatment. So for the acute migraine, for acute vestibular migraine, sumatriptan, which is to be used when you feel the onset of that dizziness, etc. If, however, your vestibular migraine is happening on a regular basis, or it's particularly severe and long-lasting, then you're probably going to want to have a preventer, something to prevent these attacks coming on. So, again, it's like common classic migraine prevention. So we use amitriptyline, first of all, 10 milligrams at night. You can bump it up to 20 milligrams. Higher doses than that often lead to so sedation and sort of feeling a bit hungover the next day. So 10, 20 milligrams, safe as houses, been around for about half a decade. It's extremely effective first-line preventer for migraine. If it's not tolerated or it's not effective, then there are some alternatives. Topiramate, valproate, candesartan are all valid and supported by NICE guidelines. NICE standing for NICE National Institute of Clinical and Health Care. So basically, excellent. So, NICE support it. So, it is, again, passed as safe. Again, migraine prevention. I mentioned this in previous podcasts. Magnesium glycinate or citrate for 200 to 400 milligrams once a day is again has been proven to be effective, as has vitamin B2, riboflavin, 1 to 400 milligrams once a day, or coenzyme Q10, 100 milligrams once a day. These are all backed up by evidence-based medicine trials up against placebo that are then published in respectable journals. So we trust them. So that's vestibular migraine. Next is Meniere's disease. Well, really, I think it's important, having made that diagnosis of that triad of the vertigo, as well as tinnitus, as well as one-sided deafness, and hence the diagnosis or high suspicion of Meniere's disease. I think it's a matter of referring that patient on to the ear, nose and throat specialist for confirmation. I think it's really important. BPPV, I talked about the positional paroxysmal, benign positional paroxysmal vertigo, and being diagnosed with the Hall-Pike maneuver. There is then a therapeutic maneuver called Epley's maneuver. Some GPs know how to move, how to be able to treat with this Epley's maneuver. It's basically a case of lying the patient down and then moving the head in various directions and to the left, to the right, to the forward, to the back. That is well documented, but actually majority of GPs will probably want to refer the patient on to the ear, nose and throat specialist again to confirm the diagnosis, and probably to have the Epley's maneuver done by the ENT surgeon. because they do it all the time. So therefore, they're probably a bit more practiced at it than us GPs. So that's the first type of dizziness dealt with, and how we're going to treat it, and the strategies and what to do, referral or treatment or manoeuvres, etc. The giddy types. The next type is the wobbly, unsteady type, like being on a boat, like being drunk. Okay, and remember the underlying cause of this? Cervical spondylosis. So basically osteoarthritis of your neck vertebrae. What are we going to do about this? Well, manipulation with a physiotherapist is very effective and really should be attempted first line. But having said that, and because the physiotherapists obviously have a good working knowledge of the musculoskeletal activities of all the joints and the ligaments and the tendons and the muscles surrounding those joints. So a musculoskeletal physiotherapist can gently manipulate the cervical spine. Having said that, actually, an osteopath or a chiropractor, they are, regulated manipulators, musculoskeletal manipulators, using different principles and tackling it from different perspectives. Osteopathy is more the soft tissue approach. The chiropractic is more the joint approach. Both of them are respectable and reliable and effective treatments. And as I say, they are regulated by their own statutory bodies, so they are safe. That is fine for them to manipulate you. And, indeed, I've had both osteopathic manipulation to my neck as well as chiropractic, and I find them both really helpful and remarkably quickly responding to both of those. Moving down the list, acupuncture. Again, a lot of patients do find acupuncture really helpful. And the rationale behind that, so acupuncture in the sense of, I'm sure I hope I'm not sort of teaching my grandmother to suck eggs here, but there are two types of acupuncture. There's what we call Eastern acupuncture, Western acupuncture. Eastern acupuncture is traditional Chinese medicine acupuncture, where we're 3,000-4,000 years old. We're relying on meridians and acupuncture points and balancing yin and yang, etc., etc. Yes, it has a role. I don't know very much about that compared with Western acupuncture. And I used to do this in my general practice, what we call dry needle acupuncture. And in a way, it's a case of needling those muscles and tendons that are, if you like, in spasm and tight, to actually relax that spasm in that muscle. And I found this very helpful in a number of conditions, certainly neck conditions. There's one particular muscle called levator scapulae, which tightens up, especially if there's a lot of tension, and to actually needle that I found really helpful. But obviously, find yourself an acupuncturist who is qualified and has been well trained, fully trained. Yoga, again, I talk about yoga as a sort of a mind-body treatment for breathing control, for mindfulness and focus, as well as for musculoskeletal reconditioning. But yoga is very good for overall rebalancing of all the sort of musculoskeletal systems. So certainly worth considering. I haven't mentioned any drugs yet. Okay, let's mention a drug. So a non-steroidal anti-inflammatory drug, ibuprofen. Why not? It dampens down that inflammation. If you strained a muscle, strained an area, then that area is inflamed. So therefore, an anti-inflammatory is very reasonable. always watch out. Anti-inflammatories can cause gastric irritation, can cause internal bleeding in the stomach. So if you do have an indigestion sufferer tendency, be very wary. Actually, I wouldn't use an anti-inflammatory if I had bad indigestion. And then there's the supplements and omega-3, the fish oils, the essential fatty acids. There's evidence that is an anti-inflammatory. Then there are the herbal products, quercetin and turmeric. Again, naturally occurring plant chemicals, and pycnogenol from maritime pine. These are all backed up by evidence-based medicine. So, a group of people divided into two, half get these supplements, half get placebo, the dummy drug, and these trials have demonstrated effectiveness at dampening down inflammation, and these trials have been published in respectable journals, so certainly worth trialing. So that's the second form of dizziness, that and unsteady, wobbly feeling like being on a boat or drunk. So on to the third type, the dysautonomic dizzy people. Okay, what are they saying? They're saying, I'm lightheaded, I feel faint, I'm about to faint. Okay, so it is because of dysautonomia. So what are the treatments for dysautonomia? Well, then there's the non-pharmacological treatments. So compression hosiery or sports leggings, tight sports leggings, push bloods back up into the circulation. A teaspoon of salt added to your diet, as long as you don't have blood pressure or kidney problems. Your doctor will check those. Increase fluid load 2 or 3 litres. And the thinking behind that is all to push more, to expand the volume of your circulation and therefore push more fluid back up into the heart, and then hence less tendency for dropping blood pressure and going lightheaded. So that's non-pharmacological. Pharmacological treatments for low blood pressure in dysautonomia are fludrocortisone. Again, I used to prescribe this very often in general practice for those. They typically were older, thin men who had postural hypotension. And fludrocortisone was excellent, actually, restoring their blood pressure and stopping their blood pressure dipping when they stood up. Midodrine is another one that, again, the cardiologists know all about, but there's another drug that is considered second line for a drop of blood pressure, particularly upon standing. Okay, orthostatic hypotension. If your form of dysautonomia is presenting with palpitations, excessive, rapid thumping of the heartbeat on the chest, particularly with prolonged standing, well, there's bisoprolol, first line, there's ivabradine, second line. So your GPs are all very familiar with prescribing bisoprolol. It's been around a long time. And ivabradine, that's second line from that cardiologist. But there are treatments. You may, want to refer that patient, your patient, or you want to be referred yourselves, if you've got this, to cardiology to have it sort of further explored and investigated. And then finally, remembering dysautonomia, there's a crossover between dysautonomia and mast cell activation. How can we treat mast cell activation to indirectly help our dysautonomia, which indirectly will help our dizziness or lightheadedness? Well, mast cell activation is treated with H1 and H2, so histamine 1, histamine 2 receptor blockers. So remember, H1 blockers, antihistamines, so cetirizine, loratadine, fexofenadine. These are second-line non-sedating antihistamines. And then the H2 blocker, famotidine, which is an anti-acid drug, okay? But it is also an H2 blocker. So used in combination, H1 and H2, very good to address mast cell activation, which will go a long way to help your dysautonomia, which hopefully will help your lightheadedness, and feeling faint. So there we are. Again, a lot of information there. I'm sorry about that, but I just want it to be as complete as possible. What do we do? Here we go, the summary. Well, basically I've covered what dizziness is and all the different presentations of it and how important it is to get the history. In order to find the diagnosis, we need that diagnosis in order to know which avenue to go down with regard to treatment or referral or strategies. Really important. And I've talked about those specific symptoms and those diagnoses. But never forget, don't just treat these symptoms, this element of your long COVID in isolation. Think about the big picture here, the overall strategies, the holistic treatment of long COVID. So I've talked about yoga for, addressing type 2, the second type of dizziness, to stretch out those ligaments and things. But generally with long COVID, we get deconditioned, don't we? Went out of condition because of being unwell. So yoga is very good at reconditioning, waking up those muscles, stretching the ligaments and tendons, getting their elasticity back and their suppleness back. Really important. And remember, stress busting, we've got to address this with yoga's good because it, focuses the now, but mindfulness, again, yoga and mindfulness have been proven to be effective. And again, published publications in journals, respectable journals, about the effectiveness of both of those. It's not all woo-woo, it's not all in the head. Both of these have their effects on all those areas in the brain that are affected in the sort of the whole functioning with regard to normal thinking, normal neurological processes. It's all their research base. Again, thinking of the overall picture of addressing long COVID, don't forget the optimal health measures, your diet, your mixed, balanced diet, to provide you all those building blocks and anti-inflammatory components and to feed your microbiota, your gut-friendly bacteria, as well as sleep. Make sure you get quality sleep. Blackout visors, so it's black. Earplugs, so it's quiet. The usual strategies for sleep hygiene. And then, of course, hand in hand with all of this is obviously fatigue management, the 3 Ps, the planning, the prioritizing, and the pacing. Really important. So you've got to tackle long COVID generally, not just chasing after one symptom, etc. So there, don't forget, it takes time. It is long COVID for a reason. It's a long condition. It takes time for natural healing. So there it is. My update on dizziness in long COVID. I hope you found it helpful, and I hope I've explained it nice and clearly. As I said in the start, this is an educational series for us, for you long COVID sufferers. Remember though, my usual disclaimer, anything that I've mentioned here, basically the advice and the treatments and strategies, discuss with your own GP, your own family doctor first, because I want you to feel safe. I want you to be safe. That's, the first, the most important thing about what we're here doing. If you found this helpful, click subscribe. I want to get this message, these podcasts, these postings out to as many of you long COVID sufferers as possible, because certainly here in the UK, so many of those services are being withdrawn, discontinued, decommissioned, terminated. So, patients are being left high and dry with nothing. So consider this as your trusted resource to seek advice as to what to do and understand it. Thanks for all the feedback you send in, all your comments and your lots of queries. And I wish I could answer all of them. I wish I could be your personal physician for all of them, but I can't because I just haven't got the time. But, keep them coming in because they help me with sort of planning future podcasts and YouTube postings. So keep them coming in. So in the meantime, I wish you well and a speedy recovery, please, from your long COVID. So until we meet again, all the very best. Cheerio now. Cheerio. Bye.